I want to talk about something today that's been bugging me for a little bit, and that's the increase in rise of certain sedative drugs in EMS transport that typically haven't been in our realm or wheelhouse, such as propofol and Precedex. And today I'm really going to focus on Precedex. So I've had several recent med control phone calls involving the use of this drug in the back of the ambulance. So what is Precedex? Well, its generic name is dexmedetomidine. It's an alpha-2 agonist, which slows your brain down, lowers your blood pressure, and actually drops your heart rate significantly and very quickly if you're not paying attention. It does have its proper place and time. It's really good at soothing somebody out that's in an ICU, that's intubated, and you're trying to keep calm, controlled, and monitored and not moving at that time. But the thing is, as we all know, EMS is hectic. It's chaos. There's so much going on. Ambulances move. There's sounds in the back of the ambulance from the sirens, from people honking their horns in other cars. These patients are unstable, and you're worried about minimal monitoring and fewer hands than what you would see in an ICU. This is not the right environment for a slow onset, low potency sedative that takes up to 10 minutes or even longer to even start to work. By the time the Precedex actually kicks in, you're almost halfway to your destination and the patient has been inappropriately sedated. Precedex is a great drug for the ICU, and that's where it belongs. It's built for that environment. You get the quiet room, you get your A-line, you have 1-to-1 ratios, you can watch every beat on a monitor. And at that point, the patient's already calm on event. This is what you want, and it allows you to keep your neuro exams. Everything I just described is the exact opposite of an ambulance. First of all, the patient's already agitated because you moved them from their bed onto a hard EMS stretcher. Most of the time, these patients are actually intubated, and that is a painful process for this patient to go through. On top of that, you add the environment of the ambulance itself, and is not conducive for this drug and should not be used. And why does this matter to me as the medical director? Well, I'm seeing an increase in transports with these patients on Precedex or even propofol from these small rural hospitals. And they're being tasked to try to get these patients out of there that are critically ill, and they're just stuck on Precedex. And the minute we start moving them over, I get that phone call about 10 minutes into the transport, the patient's moving around, their blood pressure's starting to drop, their heart rate's starting to drop, and the patient's trying to pull out the tube. And we don't have time to wait for Precedex to kick in. So typically for me, when I look at this and I get these phone calls, I said, what else can I use? First of all, to get the patient dropped down quickly to make sure the patient's safe as well as my crew. And I'll take at least some alternatives. Typically, ketamine is my go-to on these. There's also fentanyl Versed combo is the other option I typically try to use for my patients. But usually at that point, we're kind of behind the 8 ball and have to rush right to ketamine, at least get the patient settled and then try to figure out after the dust clears. So let's wrap this up, guys. We have better tools with Precedex in the back of our ambulance. When you see a patient in the ICU or an emergency room that's already on Precedex, you got to start thinking about what else can we use to make sure the patient's appropriately sedated. And we have those tools in the back of our rigs. This is Dr. Redfield, Redfield Medical Direction, keeping the EMS sharp, focused, and unfiltered. Don't let slow drugs kill your patients fast.